Hi, everyone. Welcome again. Yingzhe with Department of Healthcare Services. And you are here for the all-comer webinar to overview the department's implementation plan for the new eligibility enrollment changes under the Federal House Resolution 1. To kick us off today, our State Medicaid Director and Chief Deputy Director for Healthcare Programs, Tyler Sadwith, will start with introductions and a brief set of remarks and then we'll continue with the presentation. I'll turn it over to Tyler.
Great. Thank you so much, Yingzhe, and good afternoon, everybody. Thank you for joining us. I'm Tyler Sadwith, and I serve as the State Medicaid Director for California. And today we want to share some information about how we as a state will be collaborating with key partners to implement new federal changes to medi-cal that will be taking place over the next several years. Our overall approach to these new and significant changes is to minimize harm to members and providers to the greatest extent possible. That is our overarching goal as we prepare for these new federal changes to protect the medi-cal program. Taking a step back, we know how vital medi-cal is to California and to our communities. Medi-cal provides coverage for healthcare to 1 in 3 Californians, ensuring they can live healthy lives, get the care and supports they need, and thrive in their community. Medi-cal is really the backbone of the healthcare system in California, and it is the largest Medicaid program in the nation. As context, medi-cal is the name of California's Medicaid program. Every state operates a Medicaid program. Our Medicaid program is called medi-cal, and state Medicaid programs are funded by federal and state dollars, and they operate within federal laws and regulations. And last summer, Congress passed a bill that the president signed into law that makes the biggest cuts to Medicaid eligibility and federal funding ever in the history of the program. Here in California, as a result of this new federal law, up to 2 million Medi-cal members are at risk of losing their Medi-cal. As a result of this new law, California will lose tens of billions of dollars in federal funding used for Medi-cal. Hospitals, clinics, and other safety net providers will be particularly impacted by these massive funding and eligibility cuts, which can be devastating to local communities in terms of losing access to vital care, as well as job losses that reverberate in the local economy. Here at the department, we are doing everything we can to minimize harm to members and keep them enrolled in Medi-cal. We can mitigate the impact of this law, but we cannot avoid it entirely. Last week, the department published an implementation plan that outlines our principles and our approach for coming into compliance with these new federal requirements. That implementation plan is available on our website. Today, we will provide an overview of some of these new changes and walk through our strategy for implementing them consistent with our values and our principles. So this new federal law, as Yingzhe mentioned, called HR 1, changes Medi-cal in a few ways. For example, HR 1 imposes new financing restrictions and new and significant limitations in the way we fund healthcare in Medi-cal, the way we pay for services delivered in hospitals and nursing facilities. HR 1 also prohibits many providers that offer reproductive healthcare, family planning services, and abortion care from even participating in Medi-cal. This cuts off access to vital prevention and treatment services such as cancer screening. HR 1 also impacts eligibility for Medi-cal in major ways, and that will be the focus of today's conversation. So in particular, the law imposes new requirements for the 5 million of the 14 million Medi-cal members who are enrolled in a certain eligibility category called the new adult group. Most members of the new adult group are between the ages of 19 and 64 and do not have children or a significant disability. Many of these members will now have to jump through hoops to comply with federal requirements related to reporting how they work, how they study, or how they volunteer in order to get and keep their health care. In addition, after being enrolled in Medi-cal, Many of these 5 million members will now have their eligibility re-verified or redetermined every 6 months, which creates more red tape. The federal law also makes changes to medi-cal eligibility depending on the immigration status of certain members. So these are the items we will focus on today, and these are the items that are addressed in detail in the implementation plan. Again, these are federal changes, and here in California, we are implementing a strategy to minimize the impact to members and to providers as best as we can. We can move to the next slide, please. Thank you. So what you see here and on the next slide is a sort of high-level overview of some of the major changes of HR 1 that deal with eligibility and enrollment. I won't go too much into details, but you can see for each change, there's a description as well as an effective date. So these will be these provisions will be going live over the next several years. One thing the law does is it pauses implementation of federal regulations that were issued in 2024 related to eligibility and enrollment. So this should result in no new changes for members today. The law does narrow federal eligibility for Medicaid for certain immigrant populations. In California, this means that approximately 200,000 people will no longer qualify for federally funded Medi-cal. As I mentioned, the law imposes new work requirements for the 5 million members who are enrolled under the new adult group. And as Yingzhe will share, California is taking comprehensive steps to protect these members and to ensure they can remain enrolled in Medi-cal consistent with federal requirements. And as I mentioned, this law now requires these 5 million members to have their eligibility redetermined every 6 months, when ordinarily that only happens once a year. We can go to the next slide. The law imposes a few other changes. It requires states to check federal databases to make sure members are only enrolled in one state Medicaid program and to ensure that they're not deceased. There is a new limitation on retroactive eligibility that we want to lift up. Today, Medi-cal will provide coverage to people for a 3-month period for the month before the month in which they apply for Medi-cal, if they're eligible. So this 3-month retroactive period is really important to help sure that doctor visits and hospital stays and medications can be covered by Medi-cal for people who may have been uninsured at the time. Under the new law, for the 5 million members in the new adult group, this retroactive coverage is now limited to only 1 month. And for everybody else, it's limited to a 2-month period. And finally, for the 5 million members enrolled in the new adult group, the federal law requires co-payments for certain services. However, some services are exempt, like primary care, prenatal care, and behavioral health care, and more. And again, as you can see from the slide, some of these provisions go into effect at different points of time. At the department, we are following a set of guiding principles in our implementation planning. And these guiding principles are really designed to place the member at the center of how systems are programmed and how members experience some of these new changes. A lot of this is informed by our experience with the COVID unwinding, where we redetermined eligibility for all 15 million Medi-cal members and really linked arms with trusted messengers in the community and community partners to spread awareness and to deliver information in accessible ways so that members have all of the information available to keep their coverage. So first, right off the bat, we are 1000% committed to using every possible data source to determine on the back end if members are exempt from some of these new requirements. Or if they're not exempt, if we can determine using available data that they're actually already in compliant with these requirements. The goal here is for the state to perform these determinations on the back end using automated methods so we can avoid the red tape We want to avoid having to ask members to manually report information because we know this is a major risk for disenrollment and losing coverage. Yingzhe will describe the comprehensive steps that we're taking to maximize ex parte verifications, which is a proven method for retaining enrollment and avoiding loss in coverage. Another principle we have is being committed to clear and accessible communication. We are planning a comprehensive outreach, awareness, and education campaign that builds on our experience with using trusted messengers, such as navigators and coverage ambassadors, to spread awareness of these new changes. The goal here is for the messaging to be centered and accessible, to be culturally relevant and linguistically appropriate, and to help members understand these changes in a way that they're not written in jargon or gobbledygook. We want this to be clear so members and their family members understand what they need to do. And we're improving the member experience when it comes to renewals. We're streamlining forms in the process so that the overall redetermination experience is simpler and more effective at helping people keep their medi-cal. We're launching a comprehensive training strategy for all implementation partners, including county eligibility workers, managed care plans, providers, our tribal partners, navigators, and coverage ambassadors, so that every implementation partner is armed with effective messaging, accurate facts, and toolkits as they engage members with some of these new changes. And finally, we're doubling down on direct member engagement. It's 2026, and we know members prefer to be contacted in different ways, including mail, phone calls, and text messages. We're launching text message campaigns to build early awareness, and we're grounding our efforts in timely, consistent, and transparent communication directly to members. So with that, I want to simply acknowledge that some of these new changes can feel scary, and they do represent significant threats to our program. However, we are standing strong, and we are in partnership with all of you as we prepare to weather the storm. We are taking every possible step to protect members, and we are humbled by the interest from the community in learning more about how they can help and the role they can play with ensuring medi-cal continues to serve as a key source of healthcare coverage for people who are seeking to apply and for members who are currently enrolled. This will be a collective effort, and we look forward to sharing about the different opportunities for folks to tap in and contribute to the solution. With that, I want to thank you for joining us this afternoon, and I would like to now pass it over to our Deputy Director for Healthcare Benefits and Eligibility, Yingzhe Huang. Yingzhe?
Thank you, Tyler, for introducing our plan and the purpose of it. I didn't share this in the beginning, but wanted to just share broadly, given the number of participants that we have now, that this will be, this all-comer webinar will be recorded, and the slide deck will be shared. And also, we know the mic and the video is turned off, and we won't have Q&A in this session, given the content is pretty dense, and we want to make sure we maximize the hour to at least share what we are thinking on the plan and just kind of our overview of this so far. And what we're going to do as we are going through the deck, if questions come to you, there is going to be an email address at the end, and we welcome your questions sent to the email. And then what we will do is we're going to collect it and create an FAQ document, a frequently asked questions document, and we will be posting that up on our website. So as Tyler shared, the House Resolution 1 implementation plan on eligibility and enrollment provisions, this is the department's best thinking, at least for now, as you know, we are marching towards the policy effective dates of January 1, 2027 for the bulk of the eligibility provisions. And it's currently, we are operating without federal guidance yet at this time. CMS, our Centers for Medicare and Medicaid Services has until June 1st of 2026 to issue an interim final rule on these provisions. However, we know in the scale and volume of lives that we cover in the state of California, we must start the work now. Currently, what I'm going to be presenting to you through the end of the hour is our thinking and our initial approach. So, overview of the work and community engagement requirements. This policy is going into effect January 1st of 2027. And as Tyler shared, this is a pretty significant policy change for the medi-cal program. And it's narrowed in terms of the application of this policy to the Affordable Care Act new adult group. In 2014, we expanded coverage. We're a Medicaid expansion state that expanded coverage to individuals 19 through 64. A lot of them are single. Some of them are also a mixture of higher income parents. And these are individuals up to 138% of the federal poverty level. The work and community engagement requirements will be applied to this group, not the full 14 million lives that we cover today. And per the governor's proposed budget that was just released on January 9th, we do estimate that up to 233,000 medi-cal enrollees or members within this coverage group will lose coverage by June of 2027, which is at the 6-month mark of the implementation, up to 1 million by January of 28, and at full implementation, 1.4 million lives potentially losing medi-cal because of this requirement. What is work and community engagement requirements? It is a requirement where individuals must complete one or more of the qualifying activities that's listed in the slide deck. So having monthly income of at least 80 times the federal hourly minimum wage. So that is approximately $580 per month. And here we recognize that there will be individuals in our program that are that's seasonal work. So, an average of that over the last 6 months, or community service of 80 hours per month, or enrolled at least half-time in an educational program, or participating in a work program of 80 hours per month. So you've noticed throughout the kind of the bulleted qualifying activities, I use the word or, and it's one or more, meaning that there could be a combination of those where they will constitute what we will call you meeting the work and community engagement requirements. Basically, it just means that you have to actually participate in one of this to retain your medi-cal coverage. In the federal HR 1 statute, there is a list of what we call mandatory and short-term exemptions, and I'll walk through some of the more salient ones in a little bit. And these exemptions mean that this individual, if you fall into one of these mandatory exemptions, you won't be subject to the work requirements, meaning you won't have to meet this requirement, basically any of the bulleted items under requirement because you are exempt. And that could be done at application. I'll talk about that in a little bit, and also at the renewal time frame for the person. And for the 6-month redeterminations, we will talk about that a little bit more in detail in a little bit, but it converges. Both of the policies are effective January 1st of 2027, and it converges in the sense where it's applicable to the same group of individuals. So at the 6-month renewal mark, previously all medi-cal members have a renewal once every 12 months. So it's an annual process. With HR 1, the renewal process becomes every 6 months. So a semi-annual basis. And within that renewal process, that workflow or the requirements, work and community engagement will be assessed. Knowing that this is a very highly impactful policy for all states operating Medicaid programs, California has already posted some preliminary guidance. Now, absent federal guidance on this, a lot of what I'm sharing today is subject to change. We're doing the best we can to raise awareness and prep early. So we have published an all-county welfare director's letter because we know our county social services agencies need the guidance as soon as possible as they're preparing for the massive changes. Once this slide deck is shared, you can click on this link, or if you're very savvy with the DHCS website, you can probably find this on our website, Google it. It's All County Welfare Directors Letter 2530, and within it there's some more concrete examples from the lens of how the policy will be or should be operationalized per what we know at that time. I talked a lot about mandatory exemptions. What are they? And this is kind of the first kind of process step, for a lack of a better description here, where we must assess whether you meet this or not. If you are and fall into one of these categories, automatically you're exempt, meaning that you do not have to go through the assessment for work and community engagement. So if you're enrolled in one of the following medi-cal eligibility groups that's on the screen, American Indian or American or Alaskan Natives, for the individuals in the first bullet, those groups, we have something in the California kind of Medicaid program construct called an A code, where automatically we can exempt you based on that coding in the back end. Tyler talked a lot about ex parte, and ex parte is really a process. It's a no-touch process, meaning in the back, we are able to review your record, look at verification and data sources across kind of the breadth of our public assistance programs that are available to us, the data that's available to us, and exempt you so that the work and community engagement assessment isn't prompted for you. Those questions are not asked. So that is the ability. And if you fall in these groups, you're automatically exempt. And these are some other mandatory exemptions. And here you'll see it's a pretty long list, but some of the more salient ones here is if you're currently meeting TANF work requirements, or soon in June of 26, the CalFresh ABOD requirements, which is the CalFresh version of work requirements on June 1st of 26. And what I want to lift up is the medically frail bullet here, this exemption. This framework is very new to the Medicaid program, and it's something we're currently working to develop in terms of the policy framework. And the thinking behind this is if you meet one of these 5 sub kind of definitions, if you will, under the medical frailty definition, you will meet the medical frailty exemption. And as you can imagine, what we will have to do is look at ICD-10 codes, CPT codes, and we have to partner with a lot of our internal clinicians to kind of review the various kind of different codes and mapping it back to these categories to develop a defensible framework for this. So this is a very important exemption for us, given that we really want to maximize all the available information that's out there. And this is very heavily based on encounter and claims data, which is not an inherent kind of component of the eligibility ecosystem. And I think that's true for most state Medicaid agencies operating these types of programs. Our kind of claims world is usually separate and apart from our eligibility systems. So for states to actually facilitate a successful implementation of work and community engagement, we really need to figure out a way to bridge those data sources so that we are ingesting kind of the exemptions here that's listed into the eligibility systems. For California, and you'll see this throughout the implementation plan, we are leveraging our current system infrastructure. So our coverca.com front portal, Benefits Cal front portal, and kind of in the back end, there's systems that are operating, and currently there is in a data exchange between those systems to really facilitate kind of the intent, the spirit of the insurance affordability programs today between, you guys will hear it as CalHears and CalSAWs in the background. And these are the big business rules engines that are reviewing eligibility. So a lot of these exemptions that are not inherently known to the eligibility systems, we are currently figuring out the technology for that ingestion of the information, but those are very critical exemptions because then we could help mitigate the loss of coverage for our members. And we anticipate, as I've shared earlier in an earlier slide, we anticipate there will be a loss of coverage because of this very significant policy change. Here are some of the optional temporary exemptions. So emergency declaration, if there's like a natural disaster where there's a federally declared emergency, like a wildfire, for example, where there is a federal declaration of a public health emergency or a public emergency, we will have an ability under the interpretation of the federal HR 1 to exempt those zip codes or those counties. Unemployment rates here, very significant exemption in that sense. And here there is some literature that we footnoted, published by the Kaiser Family Foundation on the unemployment rates. And as you can see, is looking at or above the lesser of 8% or 150% of the national unemployment rate. So for us, we looked at a bunch of resources out there, including the EDD data that's published on a pretty regular monthly basis for California. And kind of looking at kind of what counties are exempt, factoring that into some of our estimates. Inpatient care and travel for care. So those we are still thinking through how we could actually use data sources to understand how to factor in these exemptions. For inpatient care, looking at place of service, potentially factoring that into the medical frailty framework, potentially for that exemption. So lots of thinking around this and awaiting anxiously for federal guidance. So how are we thinking about this from like more of like a operational kind of perspective? So in order for us to facilitate a Jan 1, 2027 implementation, we will need to revise a lot of our eligibility policies and procedures because we're doing business differently beginning in January. Streamlining the process, looking at actual opportunities, IT solutions out there that could help the member report their work activities or exemptions online in a much more easy way, like an app native to your phone, or one you could download in an app store. We're kind of looking into a lot of that opportunities to help facilitate a streamlined process there. Issuing relevant and timely guidance, which is super important. We know our counties and our systems that are helping us build the infrastructure for these new policies need clarity and very timely guidance to, make sure we're hitting certain timelines for this to work. And as Tyler noted, we're placing a lot of emphasis on outreach, putting our members first, because our goal really here at the end of the day is to mitigate coverage loss, making sure that we're automating as much as possible, and making sure our members are retaining their medi-cal. So we're leveraging a lot of best practices that during the medi-cal COVID-19 unwinding, where we really partner with a lot of implementation partners here on the call, whether you're managed care plans, clinic navigators, CBOs, providers, counties, consumer advocates, and our coverage ambassadors, our community health workers here on the call, to really look at opportunities for us to spread the word, spread the awareness, and later as I'm talking through the kind of the phases of outreach, shifting that communication style to a call to action. And here, lastly, on this slide, for the governor's proposed budget, we are looking, regardless of immigration status, the work and community engagement policies will apply if you are in the new adult group per the Affordable Care Act. So here I kind of talked about us having to look at communication tactically. Phase one is going to be that starts now. This is the awareness and preparation stage of this work, making sure we're preparing our implementation partners, our messengers in the community to understand what the department's approach is, what the law entails, what our obligations and responsibilities are, and your role. So we will be working within the governor's proposed budget. We are requesting some dollars for outreach. It's number one is federally required that we do outreach for work and community engagement. And secondly, we know that we need to engage early and look at reaching our members where they are. And during the unwinding, we had earned media, social media, and toolkits that's tailored to different audiences because depending on where you are, you may get your message a little differently. During the unwinding, we had provider toolkits, for example, videos, 15 seconds, 30 seconds, 60-second videos where we've created, posted on our website so our providers could download and play in the waiting rooms as patients are waiting and in the 19 threshold languages, in the medi-cal 19 threshold languages. Because the idea is we want to meet the member where they are to gain that awareness that federal changes are coming. Action will be needed from you, but first now, gain that awareness and start preparing. So in this very scenario for work and community engagement, we want to make sure our members know that if you are not, if you don't meet any of the exemptions, just kind of by perusing on our website, you may want to look for opportunities to, or one of these qualifying activities where, once your renewal starts happening, if you are already a medi-cal and your renewal is January of 2027, you are up first for this work and community engagement assessment. So we want to make sure you're ready and kind of shifting that communication style to a call to action with that support and action part here. And really making sure that we're telling our members, make sure you're looking out for your renewal packet. And if you folks remember the yellow envelopes that we used during the unwinding, prior to the unwinding, the envelopes were other colors, but we made a very concerted effort during the Medicaid unwinding to use yellow envelopes, and in a lot of our graphic design, artwork, videos, we have little pictures of yellow envelopes. That will continue. It's an evergreen policy that we're going to continue. And we want to make sure folks understand that you need to be looking out for those renewal packets that are coming to you, answering the work requirements assessment that will be appended to your renewal packet. In the scenario, this applies to the member. So just recognizing that it will be in two phases is tactical and strategic in the sense, because we know from experience, this is how we want to target communications. And here it's a table that just shares in terms of the impacted partners, where you as very important implementation partners can play a role here in terms of, meeting folks in the community, which, we have regular stakeholder groups where we share this information as timely as possible. So you could, share it with your constituencies or individuals that you serve in the community. And we are also soliciting, as part of these work group efforts that the department holds, comments and feedback on forms. We had to develop a whole new set of questions for work and community engagement. So we are going to solicit feedback from the community in terms of, does this make sense to you? And it will go through user testing, et cetera, to make sure that we're actually making sense, in terms of us creating forms and distributing that in phase 2. And this is through all our impacted partners as well. Already kind of talked a little bit about this, but wanting to highlight within here the time frame for this outreach, where we're targeting February, which is this month, to start an initial text messaging campaign targeted at the 4.6 million, which is the new adult group that I was referring to as part of the phase 1 component, to let them know, hey, new federal rules are coming. There will be changes in the medi-cal program. You have to pay attention to this, and we'll link it to our member-facing website on the DHCS page. and then shifting that communication through using text messaging as well, in various modalities, partnering with the managed care plans with our counties so that our message isn't contradicting each other. It's complementary, and we want to make sure it's consistent. And supporting them to respond, because we imagine in the month of October, November, renewal packets for the January 2027 group will be coming. And that is the first group in which the work and community engagement requirements will apply. So it's really learning how to fill out this new form and this new format. So lots to do in that kind of time period. Re-emphasizing the importance of all the various stakeholder roles here are providers. I talked a lot about the providers during the Medicaid unwinding, how you're ensuring the patients, the medi-cal patients that are coming to you have up-to-date information, because we need to know to make sure we have your latest address if we're mailing out renewal packets to you. If it's not, if we don't have your updated information, that's a problem. You may be disenrolled for not providing a response. I highlighting here our ECM providers, our enhanced care management providers. You are taking care of a populations of focus where more than likely they will be exempt from the work requirements. But we're kind of working through what that means currently. But very important given the kind of the populations that you serve. Our community health workers and our navigators, very instrumental as trusted messengers in the community, kind of bringing that cultural relevance and competency to the members that you interact and help, and assisting them with all the new paperwork associated with work requirements. We will be all the new questions and things associated with the work requirements. If you're doing a lot of this renewing online or applying online, will be dynamic, meaning that we're not asking the same set of questions for 14 million people, only if you are potentially subject to work requirements, meaning the online system, the online rules will kind of know you're potentially a new adult, et cetera, et cetera. It'll be displayed that way. But in the application, the paper format, we will do our best to also do that as well. But again, it is different from what folks normally see. So as with any new kind of workflow and process, we want to make sure we kind of support our members, and our CHWs and navigators will be critical. Our managed care plans was a very critical partner during the unwinding, doing a lot of the outbound messaging, et cetera, et cetera. So want to make sure we continue that partnership, that very strong partnership with our MCPs. So how would the verification work? Like the kind of the 1, 2, 3s of this. So this is the high level overview. And as guidance is released at the federal level, we'll do our best to pivot. But from kind of our understanding and our interpretation of federal HR 1, we will be gathering exemption and work requirement, or basically income information from the applicant or the member. If you're doing it online, Cal Hears or Cover CA, Benefits Cal, consumer portals, and we will be creating an exemption and a work reporting kind of form, assessment questionnaires to use for application and renewals. So that will be both for online and paper. And we will be doing a full ex parte, a no touch, basically meaning that behind the scenes, we will review and gather, partner with new verification sources if we have to, but we do have a plethora of data sources currently that we will gather this information and check if you're compliant or exempt. So we have an ability, and we're building that very strong infrastructure to support that. Just because trying to partner with as many verification sources as possible, so that we don't have to burden the applicant or the member. Again, the guiding principle here, most important, is to mitigate loss in coverage. So ex parte is such a critical tool for us. So really, we're putting so much effort in this because we want to make sure our members are retained and applicants go through the process in the most consumer-friendly way possible. And unfortunately, if number 2 just doesn't seem to work, meaning we're not able to find this or ex parte you, we will have to send you some manual paperwork. And this is truly where we don't want to, because then there is a likelihood if I send you packets of information, I may lose you in the administrative back and forth. We all know that happens. But individual does have 30 days to provide information. Verification look back. We put this in the slide deck because it's important, because this is different from current medi-cal rules. So at application, today you just apply in the month in February. You have everything's good. Yingzhou will have her coverage February 1st. It will always go back to the 1st of the month. On January 1st of 2027, there will be what we call a verification look back, meaning that before Yingzhou even applies, so she submits her application in February of 2026 because life circumstances has changed and she needs help. There is a requirement under federal HR 1 that we must look back at the month prior to the application. So in this instance, it will be January of 2026, where I must have demonstrated I have met one of the qualifying activities under work requirements, or I have met the potential exemptions. So there's some fuzziness with this policy. We're still waiting for CMS guidance, but as you can tell, this is different because in order for me to apply, I must have demonstrated that I have met some kind of, I must have met the work and community engagement requirements the month prior to. At renewal, because now this group will have 6-month renewals, I must demonstrate I've met the work and community engagement requirements 1 month between my last renewal and my current renewal. So between the 6 months, or 5 actually, really, I must have demonstrated I've met it once. So this is how currently we have interpreted, and of course, this could potentially change depending on CMS guidance. And here, the next few slides just kind of talks through step by step. How would this work on the ground from a verification perspective? I talked a lot about this kind of upfront in terms using all the available data and information on the application that's available. And if, unfortunately, I cannot verify this through ex parte, steps 1 through 4, step 5 is truly where we don't want to go because that's where we have to ask for more paper, more manual documentation, and that person will have 30 days to provide information. But this is that step where we tend to lose people. So we want to maximize our opportunities in steps 1 through 4. Here, I'm not going to go through all of it, but it's just some additional detail in terms of our kind of putting some numbers next to the steps. And we use August 2025 month of eligibility data for the new adults under the Affordable Care Act. So in August, we had 4.6 million individuals in this group. And we went through, it was kind of like a hierarchy. We went through all the different mandatory exemptions, all deduplicated, meaning all these people are unique people and there's no duplicates within each line item. And it was able to kind of funnel down to a number. So step 3 here is TBD because this is one of the exemptions. We're still kind of working through a lot of the detail. As you can imagine, there's quite a bit of new data that we currently don't house in the Medicaid eligibility world that we kind of need to piece together, get some information, and pending some guidance from CMS, et cetera. So we're hopeful that we'll get to a good number there. But steps 1 through 4 are all the automated steps. And unfortunately, even though with steps 1 through 4, we're still left in step 5 with about 2.8 million members in which we have to go and send out a request for manual documentation to verify whether they've met or engaged in a qualifying activity or have received any type of exemption. So it's still a big number of individuals. And based upon our experience, we assume that about 50% of those individuals could potentially be disenrolled due to the burdens of paperwork. So that is the number reflected in the governor's proposed budget. Here are just charts of some of the data sources and kind of where the department is at in terms of looking at verification sources to augment our existing kind of methods to verify exemptions or compliance. So we've done extensive work in this area. Medically frail, very important. We're still kind of working through it, and this is one of those high priority items that will be very impactful to this policy, and we definitely hope to get to a good place with this one. And here it just goes through every single compliance exemption category in the data system in which we're verifying this. Now, moving on to 6-month renewals, we talked a lot about this because this policy converges with the work requirements policy. It's the same group of individuals. It's that 4.6 million individuals, basically the new adult group. That number will change depending on month. We're estimating about 289,000 medi-cal members to potentially lose coverage because of this policy by June of 26. So at 6 months after implementation, and increasing to about 400,000 people in 2930. And the reason is there's more administrative burden on the person if you have to renew and run through this process twice a year versus 12. And also it's very new. And as we know, any new processes takes a lot of time to train and for folks to understand what their obligations and responsibilities are. In general, the 6-month process will follow the same process as the 12-month in terms of when ex parte happens in the system. So usually about 75 to 80 days prior to a renewal being due, the systems in the background will start reviewing ex parte sources. And this is not the member doesn't have to intervene in any of this, is not member facing. And around 60 days or so, if that person cannot be ex parte, an actual renewal packet will go out to the person. The renewal packet will be revised. We're trying to streamline it a little bit more, given that it's going to be a semi-annual basis. And in addition to, there will be work requirements questions that are new. So we want to make sure, things are as consumer friendly to the extent that we can, but ask the needed questions per policy. So that's kind of currently what we're kind of working through. And we did issue guidance in December of 25, because again, knowing that guidance is critical for us to get to implementation. So our counties and our systems have this guidance to facilitate kind of some of the work that they're doing. And similar to the work and community engagement requirements, the outreach kind of tactics are very similar in terms of the phase. We will be phase 1, that awareness and prep. This is happening right now as I'm speaking to you. And looking at messaging that we will be soliciting stakeholder feedback on. And it'll probably make sense as this is evolving, as the two policies will probably be converging in terms of the messaging, because it's the same group of individuals that we are outreaching to, and shifting that to a call to action in phase 2. So you will notice the tone of the materials will change, and then how we do this in terms of messaging it to our partners and issuing that messaging to our partners will look a little different as we enter phase 2. And to kind of maybe talk through this in a more of an example in terms of a consumer journey perspective, we have a use case here on how work and community engagement and 6-month renewals will work. And this is a very simple scenario. We know medi-cal, there's a lot of gray areas, but this is a very simple scenario. So Christopher is in the new adult group. He has a renewal date of July of 2027. We know the work and community engagement requirements are effective Jan 1 of 27. So during his renewal process, he will be assessed for work and community engagement. So in September 2026, per kind of the outreach kind of outline, he will be getting a notice from the department about all these new federal changes. And we will start the text messaging a lot earlier, but in September is more like the formal notice. Big changes are coming, pay attention. In April of 27, As I shared, we always start the ex parte process in the system, just to kind of start all the back end stuff for the renewals about 75 to 80 days prior to the renewal happening. So in April is when that process and happens. And in ex parte world, meaning we look at all verification sources that's available and whatever is in Christopher's record in the systems, we'll use all that to see if he's exempt, he meets any of the mandatory exemptions, all the maybe optional short-term exemptions maybe, and or if he's working, is compliant, so he's making $580 a month, or he's doing community service. Whatever it may be, we, in April of 27, whatever's in the system, we'll do our best to take that into consideration. And if he meets one of those, he's automatically renewed, and we send him the county on behalf of the Medicaid agency. We'll send Christopher a note, a letter saying you are successfully renewed, and see you next in 6 months. However, it could be possible that we could not ex parte Christopher, meaning all the sources out there in the world in the back end could not determine Christopher to be exempt or meeting, from an income perspective, compliant for work requirements. So we have to send Christopher a packet, a manual packet that's pre-populated, but with the work requirements insert with those questions, where he has to fill out. And so between June through that time, there's a couple of kind of scenarios that could happen. If he's approved, he submits his information to the counties. If he's approved, he will be renewed for 6 months, and the notice will tell him that. If his response on the packet says he doesn't meet the work requirements, he will have 30 days to comply, and the notice will say that. And that is a very new piece of the policy. And if he does not comply, and this is where August comes in, because you're probably wondering, well, July is his due date. Well, in August is when he had that 30-day kind of additional time to make sure that he's meeting it. Then if he's not, then his coverage will be terminated with the applicable appeal rights. If he's successfully renewed, the notice will tell him he has 6 more months of renewal coverage. So this is how it will work from a consumer journey perspective, and we're continuing to build this out. Lastly, in the implementation plan, you will see a portion of the policies on non-citizen coverage. So under HR 1, the federal statute made some changes and narrows the definition of certain immigration statuses that will be qualified for federal Medicaid coverage. This is operational October 1st, and we are estimating about 200,000 individuals that fall into these statuses, which on October 1st of 26 will no longer be a federally funded status. They will no longer qualify for federal Medicaid. We're estimating about 200,000 of these people to be impacted. And per the governor's proposed budget, we are proposing, due to kind of this change, this group will be transitioned to restricted scope Medicaid or medi-cal, which is meaning that their services will only be emergency or pregnancy related and postpartum services. So HR 1 changes this. So the only kind of 3 statuses under what we call qualified non-citizens, which is a group of statuses for federally funded medi-cal. These 3 on the page will be the only ones that are federally funded, and everybody else here, this list, will move to restricted scope medi-cal because of the changes in the definition, and also through the governor's proposed budget. And lawfully present children under the age of 21 and pregnant individuals will continue to receive federally funded full scope medi-cal. Similar to the other eligibility provisions in the plan, you will see a very similar outreach strategy. Phase 1, raising the awareness, and 2, really support and action, knowing this is a pretty massive change to the way we covered individuals and how we talk to others in the community. We want to make sure we're supporting that with technical assistance to our implementation partners. And that brings me to the last slide here. As I shared, given kind of how dense the content is, we are using the full hour for the webinar. And we're encouraging that if you have questions or if anything is unclear, to email us here. Here's the email address. And what we're going to do is we're going to collect your questions, develop responses for them. And we will be developing a frequently asked questions document for us to post on the DHCS webpage, along with the recording, as well as the presentation. So I know that was a lot of information, but luckily this will be recorded and you can share it with other implementation partners. And this implementation plan is meant to be iterative, meaning that you will see this updated as federal guidance is rolling out, as state policy is evolving through the legislative budget seasons, etc. So again, thank you for your interest, your overwhelming interest in this topic. It means a lot to us, and we are hoping this would be a very good initial webinar to engage all of you. So have a wonderful rest of your afternoon, and I'm sure we will talk very soon. Thank you so much.